This lecture accompanies Chapter 17 of your textbook, The Implications of Personality for Physical and Mental Health. We're going to focus on personality disorders specifically. Personality psychology addresses how and why people are different. This is a good thing because it makes life more interesting, allows people to survive and thrive in different environments, and some would say it's necessary for evolution. However, personality traits also have consequences for mental and physical health in a negative way. There are some traits that are socially undesirable, but there is not an exact point that differentiates between normal and disordered personality. A personality disorder is a very particular thing. It's not just an extreme on one of the personality traits. It is an enduring, rigid pattern of both inner experience and outward behavior that impairs a sense of self, emotional experience, and expression, goals, and the capacity for empathy or intimacy. These disorders include unusually extreme personality attributes and often a denial or distortion of reality. These disorders often lead to psychological pain for the person with the disorder, but they particularly lead to problems with others. There is an important caveat that I want to mention, and that is the need to consider cultural context in defining what is unusually extreme behavior. Personality disorders significantly affect social relationships. Other people are required for the symptoms to even be expressed or observed for others. For example, lack of flexibility is seen when a person interacts with others. Deceitfulness requires another person. They're stable over time. Disorders are about as stable as personality itself. A personality disorder typically becomes recognizable in adolescence or early adulthood, and symptoms last for years. Some disorders are what is called egosyntonic. This is when symptoms are seen as normal and valued aspects of the personality by someone. And this person with this personality disorder sees other people as the problem rather than themselves. These are among the most difficult psychological disorders to treat. Psychological disorders in general have been codified by the Diagnostic and Statistical Manual, or the DSM. The DSM is currently in its 5th edition, but its first edition was in 1952. There was a lot of controversy over the DSM in regard to how they define many things, including personality disorders. Early editions of the DSM were really focused on the experience of clinicians rather than empirical data and research. There was, for many years, diagnoses in the DSM related to things that are not disorders, including homosexuality and gender identity broadly. There are two main purposes of the DSM. One is to make diagnosis more objective, and that has occurred with more recent versions that are now based more in research than just on clinical experience. Making the diagnosis more objective ensures a common vocabulary for describing problems, and this should make discussions and analyses more useful, and so it's especially important for research. Second, it's for insurance billing, so that care for a patient can be reimbursed. There are two systems for personality disorders. The old system with a list of the disorders and the symptoms, and then the new system for personality disorders in the DSM-5, where they have not clustered the disorders and they've deleted quite a few. I'm going to take a minute here to describe the old and the new system because for many people the old system is still being used, especially in research if they had started with the older system. So it had been that the 10 major disorders were clustered into 3 groups. Cluster A involved odd and eccentric patterns of thinking. This included paranoid, schizoid, and schizotypal personality disorders. Cluster B was the cluster of personality disorders that were characterized by emotionality, being erratic and dramatic, and this cluster included borderline, narcissistic, histrionic, and antisocial personality disorder. It was known, or is known now, that many of these in this cluster are particularly stable. Cluster C was called the anxious fearful cluster, and that's because it included avoidant, dependent, and obsessive compulsive personality disorder, all of which share a high level of anxiety. The new system is much more scientifically grounded. Disorders are described using 4 areas for each disorder. So every disorder is described in terms of how self and identity is affected, self-direction, empathy, and intimacy. And there's also a requirement that there is the presence of pathological personality traits, which we'll talk more about in a bit. In the new system, 4 disorders were deleted because they weren't sufficiently coherent, common, or distinct from the other disorders. And these were schizoid, histrionic, dependent, and paranoid. It's important to recognize that even among the 6 remaining personality disorders, there is a very high comorbidity. The symptoms of these personality disorders overlap with each other so much that it can be difficult to distinguish one from another. In addition, diagnosticians sometimes determine that particular individuals have more than one personality disorder. This lack of agreement has raised concerns about the accuracy or validity and consistency, also known as reliability, of these categories. First is schizotypal personality disorder. This is an extreme pattern of odd beliefs and behaviors and difficulties relating to others. Part of this difficulty is due to their superstitious beliefs and unconventional behavior and extreme social anxiety. Similar to schizophrenia, when schizotypal is at its extreme, but you can distinguish them by the fact that in schizotypal personality disorder, the person does not lose all contact with reality. Therapy with individuals with schizotypal personality disorder can be very difficult. Most therapists agree on the need to help these clients reconnect and recognize the limits of their thinking. Therefore, cognitive behavioral therapy is often used to teach clients to objectively evaluate their thoughts and perceptions. Sometimes speech lessons and social skills training is offered. Finally, antipsychotic drugs appear to be somewhat helpful in reducing certain thoughts, but not always or for everyone. Narcissistic personality disorder is an extreme pattern of arrogant, exploitative, and problematic behavior combined with a notable lack of empathy. The individual with narcissistic personality disorder believes that they are superior, even against evidence. This person often expects special treatment and feels entitled, doesn't think the rules apply to them, and can feel justified in taking advantage of others. The prevalence of narcissistic personality disorder is up to 6%. Some famous examples of individuals thought to have this disorder include Hitler, Mussolini, and Stalin. Psychodynamic theorists, more than others, have theorized about this disorder, focusing on the impact of cold and rejecting parents. They interpret this grandiose self-presentation as a way for these clients to convince themselves that they are self-sufficient and without need of warm relationships. Research has found increased risk for developing the disorder among children who have experienced abuse. Cognitive behavioral theorists propose that narcissistic personality disorder might develop when people are treated too positively rather than too negatively early in life, and that the individuals with narcissistic personality disorders were taught to overvalue their self-worth. Borderline personality disorder is one of the most well-known personality disorders. It's an extreme and sometimes dangerous pattern of emotional instability, emotional emptiness, confused identity, and tendencies towards self-harm. All of the personality disorders are rather mixed bags of indicators, and BPD may be the most mixed of all. It can be difficult to find a coherent common thread among the 9 characteristics. However, one can identify emotional instability and feelings of invalidation as being core to this personality disorder. The pattern of the symptoms in BPD often results in suicidal ideation or suicide attempts. There's also a disturbance in identity. People don't know who they are regard to values, goals, and sexual identity. And the theory is that this is partially due to something called splitting, where individuals can see people, including themselves, as all good or all bad. The prevalence of BPD is about 2%, but more recent research suggests it might be as high as 6%. There's a myth that it's a female disorder, but it actually is equally likely to occur in men and women. The course of the disorder varies. In the most common pattern, the instability and risk of suicide reach a peak during young adulthood and then gradually wane with advancing age. Psychodynamic theorists look to early parental relationships to explain the disorder and propose that it is due to a lack of early parental acceptance and or abuse and neglect by parents. There's some biological abnormalities that have been documented in individuals with BPD, such as an overly reactive amygdala and an underactive prefrontal cortex. In addition, sufferers who are particularly impulsive apparently have lower brain serotonin activity. There is a very well-validated treatment for BPD, unlike with the other personality disorders. It's called dialectical behavioral therapy, and it was designed by Marsha Linehan, who herself has borderline personality disorder. It's largely taken from both cognitive behavioral therapy and Eastern perspectives, Zen Buddhism in particular, and it is often delivered in a group-based context. It's focused on increasing distress tolerance, increasing mindfulness skills, improving interpersonal effectiveness, and overall emotion regulation. Avoidant personality disorder is characterized by expecting the absolute worst from others and needing constant reassurance. There is an active inhibition of emotional expression and yet deep cravings for affection and social acceptance. The estimated prevalence is 2.4%. One very notable individual who is theorized to have had avoidant personality disorder is Henry Darger, and he was an individual who lived in Chicago for decades without interacting with anyone, and after he passed away, it was found that he had spent decades of his life writing these fantastical stories about children and painting swaths and swaths of paper with pictures illustrating the stories. Individuals with avoidant personality disorder often feel socially inept, inferior, or unappealing to other people. They often have no close friends and avoid any activity or occupation that involves contact with others. Anti-personality disorder is an extreme pattern of deceitful, manipulative, and sometimes dangerous behavior. Illegal activities such as vandalism, theft, and drug dealing are common among individuals with this disorder, including impulsive and risky behaviors like reckless driving, drug abuse, and dangerous sexual practices. The problems these individuals might cause for other people don't bother them. Prevalence is up to 3%. It is 4 times more common in men than women. The DSM-5 requires that a person be at least 18 years of age to receive this diagnosis, but many of the symptoms may appear before 15 years old, such as what is seen in conduct disorder. There are a number of biological factors that might play a role in this disorder, including lower levels of serotonin, which impacts impulsivity and aggression, deficient functioning in the frontal lobes of the brain, and abnormally low levels of anxiety and arousal, leading them to be more likely than others to take risks and seek thrills. Obsessive-compulsive personality disorder is one of the more prevalent disorders. It has a prevalence of between 2% and 8%, and it's not the same as obsessive-compulsive disorder. It is less severe because it does not include specific compulsions. That said, OCPD may affect more areas of life and be harder to treat than OCD. OCPD is an extreme pattern of rigidly conscientious behavior, including an anxious and inflexible adherence to rules and rituals, perfectionism, and a stubborn resistance to change. There is a lack of sense of proportion in OCPD, and it's very difficult for individuals with this disorder to determine when rules don't apply or details are not important. Ironically, although perfectionism is a hallmark symptom of this disorder, there is often an inability to throw things away as they think they might need it later. OCPD is difficult to treat through psychotherapy. This might be in part because its basis is biological. Particularly, connections between the frontal cortex and the limbic system might be involved. A psychological barrier to treatment, though, is that people with OCPD the disorder is egosyntonic, so people with this disorder are, relatively speaking, less impaired in their daily functioning than are people with some other disorders. Some people with OCPD claim to like being the way that they are, and to a degree, the traits associated with this disorder may be useful. There is something to be said for a surgeon, an accountant, or a data analyst who checks everything several times, whether it is really necessary or not. On the other hand, some of the complications that often go with OCPD, such as worrying about a lot of things that don't really matter, can really interfere with life for these individuals. Several psychologists have attempted to identify key dimensions that underlie the personality disorders. In some cases, their goal is similar to that of psychologists seeking to identify the essential traits of personality. They hope to identify a set of dimensions that can organize the entire range of personality, including both normal and abnormal patterns. A new way of organizing personality disorders doesn't use clusters and tries to move beyond the use of discrete categories. This approach recognizes that psychological maladjustment is more a matter of degree than of kind. And the way that this is thought about is taking the big five and flipping them a little bit and modifying them a bit and calling them the bad five. So these trait domains are negative affectivity. So this could correspond to high arousal, high neuroticism. This is a tendency to feel negative emotions. Detachment is a tendency to withdraw from and avoid emotional contacts with others. We can think of low extroversion here. Antagonism, including deceitfulness, grandiosity, and callousness, can be associated with low agreeableness conceptually. Psychoticism is a tendency to have bizarre thoughts or experiences and eccentric behavior. This would correspond to excessively high openness. Finally, disinhibition is a lack of self-control that leads to impulsive behavior, and we can think about this as low conscientiousness. One example of how a personality disorder would be characterized in this way is antisocial personality disorder. Someone with APD would be characterized as being extremely low in conscientiousness, excessively low in agreeableness, and very high in extroversion. Whereas schizotypal is more characterized by low extroversion and very, very high openness. We have to be careful about pathologizing behaviors. Describing all behaviors as the result of mental illness is a problem. There are disadvantages to describing so many behaviors like we've done in this lecture as pathological. On one hand, describing behavior as the result of mental illness is too easy because then you're just giving a diagnosis to something. However, what we need to do is understand the nature of mental health, and to do that we need to understand both normal and abnormal forms of personality. Talking about personality disorders and all psychological disorders can be misleading, sometimes a little, sometimes a lot. No one fits the exact criteria for any disorder category. People often have characteristics of several categories, and several disorders are difficult to apply consistently and reliably. Labeling can limit understanding by leading to not taking the person's feelings, outlook, and rights seriously. It can also decrease empathy among people. The stigma associated with mental illness is significant and very problematic. People who are identified as being, oh, she's bipolar or he's schizophrenic or she's a borderline. All of that is reducing an entire human being's experience into one term or word and disregarding all other aspects of their personality and their lived experience, of which mental health is only one aspect.